Welcome back again. So this is our final session. Thanks, everyone. I hope that you've stuck with us. So this one should be great. It's about Arthramid. So thanks for Arthramid. So it's Florent David. He is graduated in Lyon in France and did a residency in Montreal. He holds specialist qualifications with the American College and European colleges, and he's currently the head of clinical services in Doha. So his talk is on 2.5% hydrogels, the current research and treatment. So thank you, Florent.
Thank you, Finola. So yeah, we are going to discuss the use of Arthramid and as a future treatment for arthritis. So just I want to disclose first that we have two types of polyacrylamide gels on the market. I don't know if they've reached, the two of them have reached Australia, but I got involved in clinical research studies with Noltrex Vet, which is one of them, and more recently with Arthramid Vet. I did not receive any remuneration, so I can freely talk about my experience and the research information I've gathered. The two hydrogel, to my knowledge, have not been compared side by side, so it's quite difficult to know which one is better than the other one. But we have publications, but maybe more with Arthramid by now, but some also with Noltrex. So keep in mind the government regulation in every place in the world if people are not just based in Australia, but that's important to keep in mind. So what is 2.5% polyacrylamide gel? How does it work? We're going to cover that if some of you don't know the product. So the 2.5% polyacrylamide gel is a gel which is surrounded by water. It's a patented technology called inline cross-linking technology, and where during this process of fabrication, making up the gel, you force water molecules into the cross-linked polymers of polyacrylamide. That will provide a gel that has a great molecular stability and ability to retain viscoelastic properties in situ. So the 2.5% polyacrylamide gel, because it's mainly water-based, is hydrophilic, and due to its chemical structure, is made in a format that is irreversible and has a steady state backbone with lightly bound water molecule that can interchange with water molecule of surrounding tissue. So will still interact somewhat with the tissue for sure, but is relatively steady. So once you produce the molecule after branching, basically the polyacrylamide chain as you get a 3D network of cross-linked polyacrylamide that is formed rather than a random organization. So you will see on the next picture, we get a relatively homogeneous and very well repetitive scheme. So any residual monomers that are, like released during the manufacturing process are just removed during the process of fabrication. So the molecule is pretty large, biocompatible, and you have non-toxic elements inside. And it's also not really toxic from what we can get from the company on the nerves. And it will maintain its viscoelasticity in situ. So that's how it presents, usually in syringes of 1 ml like this. So you open and you take whatever you need to inject. It's presented sterilely. It's very handy to use. And this is the gel that you can see now on microscopic electron microscopy. And it's important to realize like the architecture, the 3D architecture of this gel. And you can appreciate that the gel is organized in such a way it's quite repetitive. It's not a random organization. So that's all about the manufacturing process. This histo slide is a normal joint where we have like a reminder of the different layers of the synovium and the joint capsule here. So the synovial lining is right here, and you can see synoviocyte, a couple of layers of cell, 1 or 2, usually, and underneath you have what we call the subintima. And under that, you have like collagenous tissue that can be fat as well. And then you find your joint capsule. That's a normal joint. In the subintima, you have mainly like fibrous tissue with blood vessels. So when you debride in arthroscopy, when we clean that up quickly, we can expose the fat and it bleeds, because there are plenty of blood vessels in the synovial membrane, especially when inflamed. So in 2016, a group in Denmark, Christensen and collaborators, showed that the 2.5% polyacrylamide incorporates into the synovium at approximately 4 weeks post-injection into a joint. And until that point, it really lines into the synovium. And the histological appearance that you get at 4 weeks, so they've done several like sampling over the time and persisted up to 2 years in OA joint, osteoarthritic joint, or control joint. The majority of the gel is recovered in the subintima layer, so just underneath the synovial membrane, or basically underneath the layer of synoviocytes. And what you get is a synoviocyte hyperplasia and hypertrophy, and then angiogenesis and collagen deposition. So we're going to come back again on those things. So this is a joint that has been injected with Arthramid. Here you can see in the subintima, you have a blue haze. So the gel is kind of like located in this part at this stage. And if we look from closer, you remember before that we looked at the synovial lining, we had only 1 or 2 maybe layers of cells. Here you have like a super synovial membrane, quite, like developed with multiple layers of synoviocyte that have come up. If we again like go back to the electronic microscopy, and thanks to Liz Girvan from the Center of Electron Microscopy at the University of Otago in New Zealand, you can see the gel is in red, indicated by the red arrow here. And we can appreciate the bubbles that we used to see before. And in between the portion of the gel, you can see some collagen. This is the blue arrow, which is kind of layered between the different organization of the gel. So the scaffold is basically being progressively, cells are migrating inside and something is happening. We can look at this one again from closer, but that's the same kind of appearance. Again, the gel and some collagen fibers that are put between the different bubbles of the gel. So what is the mode of action of the 2.5 polyacrylamide gel? So it's been tested in a goat model where they did like created osteoarthritis. And what you can see in this little graph, so the top one, you can see they've looked, the researchers have looked at the elastic modulus of the normal and OA joint capsule. And in orange, you can see an OA joint that has lost some elasticity just due to the condition, the osteoarthritis that makes the joint stiffer. And a non-OA joint, would have more elasticity than an OA joint. So that's the pathological process that caused this loss of elasticity. Now in the graph underneath, you can see that so that's a goat that has been treated with Arthramid. And what you can see is that the non-OA joint on this one that has also been treated with Arthramid has a strain at about like 200 and maybe 10, something like that. And the OA joint that is in purple that has been treated also with Arthramid recovers higher elasticity. So that's something that has been proven as a mechanism of action, so an increase in joint capsule elasticity. So this process is happening during the first 4 to 6 weeks. So when the gel is basically being integrated in the subintima and joint capsule as well, you get this thickened membrane, and that will increase the tissue elasticity. So this was again shown by Tnibar and collaborator in this goat model. It may improve also the load transfer and ability of the OA joint to function. This other mechanism of action is suspected but not been proven so far. During the first week after injection, while the gel is still within the joint space but adherent to the synovial membrane, you get some sort of a protection, and the synovial membrane is not exposed anymore to the cytokines that are released into the joint fluid. So that's a suspected mechanism of action as well. That may explain why in the early phase, like the inflammation in the joint will decrease, and sometimes also we can see some improvement in clinical signs. So just to go back now on what has been published on 2.5% polyacrylamide gel, so Arthramid, you can see we have like the first 4 studies are really like when it all started in horses. So started in 2012 with Janssen and up to 2016. The cases that were treated, clinical cases, they were all like kind of lost cases where there was no improvement or very advanced OA. So I'll go through those studies, but and that's the time I joined to do some research with Leda Clifford and Jason Lowe as well, and many other collaborators. We have looked at it from a different angle and thinking, okay, maybe instead of targeting only advanced OA, we should see what it does on early OA and see how it compares with other treatment that we would be more keen to use at these early stages. So I will discuss, of course, this paper of 2019 and our last publication. So the first paper of Janssen is the intra-articular use of polyacrylamide hydrogel as a treatment of OA in the distal interphalangeal joint, published in the German journal. And it's a case series of 12 horses. So it's not a lot of cases for sure, but there were 12 horses with this disease diagnosed by intra-articular anesthesia, radiography, and MRI. They received 1 cc of 2.5% polyacrylamide gel. Lameness was reassessed at 3 months post-injection, and all horses were previously treated with triamcinolone acetonide or HA or ACS, so the IRAP. And at 6 months, what you can see in this group, you have 8 horses that were lame-free, so bringing a percentage of lame-free horses of 67%. 2 were improved and 2 were unresponsive. So not a magic drug, but again, like considering that you're dealing with a group that has not been improving with other treatment, you're kind of happy to get about 70%, 65, 70% of horses responding. Now, Dr. Knibar in Denmark came up with a controlled clinical trial on the efficacy of intra-articular polyacrylamide hydrogel in horses with OA, and that was presented at the ECVS in 2014. So 40 horses taking equestrian discipline, 20 in each group. The groups were either 2.5% polyacrylamide or triamcinolone plus HA. All the cases were fetlock OA that was diagnosed by intra-articular anesthesia, radiography, and MR. And you can see this time, instead of injecting 1 cc of 2.5%, the dose was doubled to 2.2 ml, and 10 milligram of triamcinolone, 20 milligram HA combined in the other group. And what we can see is that we have lame-free horses at 1, 3, and 6 months are displayed below, 55% at 1 month versus 15% with triamcinolone, and at 3 months, 65% with polyacrylamide, 40% with triamcinolone HA, and 75% at 6 months with polyacrylamide gel, while we have 35% with triamcinolone and HA. So interesting result, again, showing some advantages to use on advanced OA, the polyacrylamide gel. So this same author, Dr. Knibar and collaborator, then made a kind of international multi-center prospective study on testing the efficacy of the polyacrylamide gel. And what they did different on this one, it was multiple centers, and they followed the horses on a long period of time, 24 months. So it's always difficult, in clinical practice to run those kind of studies. 43 horses, mainly like equestrian horses, but a bit of racing horses as well, race horses. and mainly fetlocks, again, treated with OA. And what we can see, the 2 ml was again used in this group. They had a blinded assessment of lameness. And what you can see is that 1, 3, 6, 12, and 24 months, you have 59% of the horses at 1 month, 69% at 3 months, 79% of the horses, 81% at 12 months, and 82.5% at 24 months that were free of lameness, respectively. So the joint effusion at baseline was normally distributed, but at 24 months, only 78% had 78% of the horses had no effusion anymore. So helping the joint overall appearance as well and the health of the joint in general. So Andy Baith and collaborator in the UK have done another study where they use basically the polyacrylamide gel Arthramid on 20 horses that were non-responsive for OA of the interphalangeal joint. And this was a prospective study. 20 horses were sport horses diagnosed with pastern or coffin joint OA on MR. They were all persistently lame after previous corticosteroid treatment. Average length of lameness was quite long, like more than 15 months. And the degree of lameness was 3 out of 10 at day 0. So not super lame, but kind of the horses that never really get better. They received 1 ml of 2.5% polyacrylamide gel, and 18 horses were available for follow-up at 12 months later. And you can see again this same kind of number between 65 and 70% return to full function. Some of them improve, but not sufficiently to be back to full function. And you had 16% of the horses that failed to improve. So that were the studies that were covering like relatively advanced OA versus the study that published by Clifford et al. In 2019, where like 2.5% polyacrylamide gel was used in the management of lameness in this time only flat racing horses. So 49 horses were included, 89 joints were treated, mainly intercarpal joint, a little bit of fetlocks, but mainly like 88% of intercarpal. And the lameness grades prior to injection were between 2 and 3 out of 5 AAP grading system. And you can see the radiological score were pretty low in most of the cases. So with radiological score of 0 out of 3 or 1 out of 3 in most of the cases. They received 2 cc's of Arthramid in the joint, and you can see at 1 week post-injection, none of the horses returned to soundness. 43% at 4 weeks. At 12 weeks, you had 67%, and at 24 weeks, 65%. So the effect seems to happen between 1 week and 4 weeks, and stabilization between basically 12 weeks and up to 24 weeks. So this is the paper that we've just got accepted. So it's hot from the press, basically. This time we came back thinking, okay, look, in this previous study, we didn't have any comparison. So we need to get this level of study where we have a double-blinded study. So, and we published it in the Journal of Equine Veterinary Science. So it's available online easily. And in this paper, really, like we wanted to get a prospective study that was double-blinded. So people that were diagnosing the horses and injecting the horses, reassessing the horses were not the same. So there was no interference on that point. Also, the trainers didn't know what was injected in the joint. And we compared basically, it's a relative efficacy because it's not against the placebo, but we wanted to compare the polyacrylamide gel against triamcinolone acetonide and also HA. So we had 3 groups. And again, the target population was racing thoroughbreds in training and with mid-carpal joint pain. So 31 horses got included. They were older than 2 years of age. They were all in training for at least 12 weeks. So were up and galloping at that stage when they were included in the study. They were enrolled if lameness was isolated to the mid-carpal joint by clinical examination, so lameness, effusion, reaction to flexion. And of course, like in intra-articular analgesia was performed to confirm that the pain was coming from this joint. There was a standard radiographic series performed on all horses that entered the study, and some grading was given. The horses that had fracture or chip would be excluded automatically, because we are well aware that this is not the best way to treat those horses. And the horses that also had surgery within 12 weeks from this occurrence of lameness were not included. If they had a medication given in the last 4 weeks, they could not be included as well in the study. So they were randomly allocated into the 3 treatment groups, and the treating veterinarian administered one of the 3 treatments. So you can see 50 milligram, which is equivalent to 2 mL of 2.5% polyacrylamide injected intra-articularly. Another group was 12 milligram of triamcinolone injected intra-articularly, and the last group was 40 milligrams, so 2 mL of HA, followed by further 2 treatments of 40 milligram IV at 7 days and 14 days at as per label recommendation. The trainer, as I mentioned before, was blinded to the treatment, so the expectation of all connections was that the horses were to be kept in work. So there was no real interruption of the training schedule and racing schedule. So horses were re-examined at 2, 4, 6 weeks by the examining vet, blinded to the treatment groups, okay? And the horses were assessed across 3 variables: lameness, joint effusion, and reaction to flexion. So that's a bit of a summary of the study. So the baseline, when the horses were included, put into one of the 3 groups, and then reassessed at 2, 4, and 6 weeks. Some horses got excluded because they could not really tolerate the continuation of the exercise, or they got excluded and that was considered as a failure of the treatment, whatever group they were in. Or some horses got excluded as well because something happened, like an injury, a castration, or something like that, that was basically kicking them out of the study. So we can see the pre-admission variables, and what is important to note is that in each group, age, the type of racing that they were doing, the lameness range or the effusion range, or the reaction to carpal flexion, or the radiological grade were not different in any of the groups. So we had p-values that were over 0.5. And what you can see here is that the grade of radiographic changes were pretty low. So from 0 to 2, the grading system was up to 4. So relatively mild changes. So this is probably the most important one, because that's what the owner, the trainer, will look at. But if we look at the results here of the lameness at 6 weeks, we can see that the group that was treated with polyacrylamide outperformed the triamcinolone or HA group, and that was pretty significant. So 10 horses at 6 weeks were lame-free out of 12 versus 3 in the triamcinolone group out of 11, and 4 in the HA group out of 10. So I think that's quite significant as a result. And again, some other studies performed with other polyacrylamides, such as Noltrex, would not have produced data like that. So it's a bit more difficult to compare, because they talk about improvements in lameness. We were really interested from the owner-trainer angle when the horse is basically free of lameness and can return to exercise. An improvement of lameness is always welcome, but it doesn't tell you that the horse is ready to go back to performance. So again, joint effusion at 6 weeks, we had some interesting result again. So we had more horses that had resolution of the effusion at 6 weeks in the polyacrylamide group, so 6 out of 12. And that was, again, significant compared to none out of 11 with the triamcinolone or none with the HA, keeping in mind that those horses were kept at exercise. And for the reaction to flexion, we saw also a difference between the different groups, but this difference was not significant. Coming close to it, but not significant. So the reaction to flexion was also improved in the polyacrylamide group for 50% of the horses versus 1 out of 11 for triamcinolone and 2 out of 10 for HA. So what are the conclusions from this last study? We can say that the 2.5% polyacrylamide gel in this study design, which is again double-blinded and I would say pretty well designed, especially considering that we did that in a clinical environment. You know, it's not an experimental study. They are like naturally occurring lameness and osteoarthritis. So the 2.5% polyacrylamide was superior to both triamcinolone and HA treatment for the management of midcarpal joint disease in horses that were kept in exercise. And that's also novel compared to other studies published with polyacrylamide, because before, in the older studies, there was always a resting period provided after the injection. We could see, and you will see that in the paper, that the group that had basically the injection of polyacrylamide was followed for 6 extra weeks after the 6 weeks time point, and the same results. So the horses that were lame-free at 6 weeks were still lame-free at 12 weeks. So there is a lasting effect for at least 12 weeks, as shown in this study. So we had mild signs of radiographic signs that indicate that as a change a little bit, we can also consider using Arthramid in cases that are early in the process of osteoarthritis. It's not only a medication that will be valuable for advanced osteoarthritis only. So you should think a little bit about that, because when you see the results, and also the results obtained when you keep the horses at exercise, I think it's a very interesting concept. So what was a little bit shocking and disappointing, I have to say, is the use of triamcinolone in the face of an ongoing exercise may give poorer outcomes. So we usually don't use that medication this way, or personally I don't. We rest the horses for the anti-inflammatory to take action. So maybe the design of the study was not playing in favor of triamcinolone, but it's not the first time that we show that triamcinolone is not necessarily the best treatment for osteoarthritic joints. So that's the end of it. So I would like to acknowledge the Australian Veterinary Association for giving the opportunity to talk, and the VetFest Marketplace being a great audience, I hope. Also my colleague in New Zealand, Dr. Leda Clifford, Dr. Jason Lowe. So the talk has been sponsored by IMS, and they are distributing Arthramid, so feel free to contact them to know how to get your hands on this interesting product. And also thanking my colleagues at the EVMC, Equine Veterinary Medical Center in Qatar, that are working hard while I'm talking here. They are in the hospital. So I just finished an arthroscopy, came here for the talk, and now I will have to go back after some questions. So I hope you enjoyed that. I wanted to remind you that in 2022, we have the FIFA World Cup. So for the people that are passionate about soccer, Qatar is a great place to be. That's one of the beaches where I go and do a lot of kite surfing. So you can see me in this corner over there doing kite surfing while the kids are enjoying playing in the sand. So happy to entertain any questions. Thank you very much for the attention.
Thanks, Florent. That was great. Jeffrey, do you want to jump in if there's any questions? Otherwise, I can ask one. So have you used Noltrex, and how does it compare? I'll just say to you that Noltrex isn't registered. So Arthramid is registered in Australia, but not Noltrex, but just as you mentioned at the beginning of the talk.
Yeah, so I use Noltrex so before being in Qatar, I was in Norway, and before being in Norway, I was in the US. So when Noltrex got brought to the US, I was one of the vets selected to basically test the product on specific cases. So we enrolled some clinical cases, and there was a publication came out of it. So I would say I have used Noltrex enough to get an opinion, but now the number of cases I've treated with Arthramid is way higher. But what I've seen with the Noltrex is, so the biggest difference is that the product is a 4% polyacrylamide instead of a 2.5%. And I don't know if there is a problem of tolerance in the very initial phase, but I've seen quite a lot of horses that would develop some very puffy and flary type of joints after injection of Noltrex. Not to say that the horses were lame, because that would be lying, but enough to annoy me a little bit, because I had the clients, on me, oh, do you think it's normal? Because nobody knew the product at this time, so they were really like stressed out. But I have seen some very good results as well with Noltrex. To be honest, I would be again lying to say one works better than the other, and I really want to see one day a study comparing the two products side by side, because that's what is, if you listen to the companies that produce them, they always claim their ones is the best. But I think we need something a little bit more serious than that really compare them side to side. The products are, it's not just about the percentage. I think the gels are also different in the way they manufacture them. For Noltrex, they have added some silver ions inside to maybe improve like the risk of septic joint after injection. But I have to say that I have never seen one in the way I practice. Neither with Noltrex or with Arthramid. So I think the products are pretty safe from that angle. So just to make the answer a little short, I don't think I can give an opinion on how they compare lameness improvement wise, but I've seen a difference in how the joint reacts to it. For Noltrex, after the injection has been done, this puffiness will disappear. And I think for a while, the company was aware of that and recommended to inject it with corticosteroid at the same time. So they were concerned about some inflammation caused by the injection immediately after injection. I don't know if they still recommend it anymore, but yeah, that's something I've observed. I think we need to, earlier on, we discussed Prostride. Also, Prostride has a cost, like those products are not cheap. Nothing will beat the corticosteroids in terms of cost. HA is quite expensive, I think, for what you get, but that's we've learned how to combine them. Some people question the value of that more and more, and I think from the cost point of view, you can also be a bit critical about that. But I agree, like the cost of, for the small joints like tarsometatarsal, DIT, I usually put 0.5 ml to 1 ml. For the joints like fetlock or pastern joints or carpi, I would put, like 2 to sometimes a little bit more, depending. So the cost can fly quite quickly. I think, considering that you have a long-lasting effect, I always put that in front to the client and say, look, if you do corticosteroids, first of all, sometimes they don't work as good, and they can impact also the regeneration of the cartilage if there is still some happening in this joint, or affect the balance between catabolism and anabolism. But yes, you may pay more at the time of the injection, but that may last longer. But I really make sure to not have people disappointed, is to explain that none of the medication are magic and will fix all the problem. That's one thing. And also I prepare them with, when I inject Arthramid, that most of the positive outcome are observed from 2 to 4 weeks. So, like if they expect after 1 week or a few days, like corticosteroid, when it works, to have the horse like lame free, they are going to be disappointed. So you need to prepare them, because it's a bit of a shift of mindset, how to assess the cases. But I am in the caseload I have, I work maybe 60-70% of the caseload I deal with now is Arabian. and the propensity of metabolic syndrome is quite high, or if they are not metabolic syndrome, they have gotten some laminitis induced by overfeeding of concentrate. So for me, this medication is really like important in my day-to-day practice, because when I don't want to run a test of insulin or this and that or an ACTH, I'm in a rush. I don't want to take risk. That's my drug to go, versus a corticosteroid if the client has the money to pay for it. Yeah.
And how long do you find it's lasting? The response to Arthramid, is it a year or longer, 2 years or?
This I have to say, usually the first time I injected Arthramid was on one of my own horses, and I've never re-injected it again. The horse had poor conformation that was bred by my brother, like my brother being the brother of a veterinarian should have called me, but basically the foal was born with toed-in conformation, the fetlock were varus. He called me when the foal was almost was a 2-year-old and say, "Oh, look, it doesn't look great." And I'm like, "Yeah, what can I do now? It's gonna be stuck with this problem." So of course the horse got lame and started to jump at the age of 5. And so I put 2 cc's in each coffin joint, and we are very careful with the shoeing. And since then, I hasn't looked back. So that was not the only thing done, but I think it's always tricky to know exactly how long it lasts. The studies that have been done so far, we need to give them the credit. Some of them have followed the horses up to 2 years after, and we see some long-lasting improvements. So I think we can expect, and that's always what I put forward with the client to say, look, you may pay more now, but as long as you respect also and follow the recommendation that have been made on the side in terms orthopedic shoeing, type of exercise, schedule, blah, 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 you will get a good return on value, I think.
So potentially even longer than 2 years, depending on the case. Could be that maybe it doesn't need another 2
Yeah,
years.
and again, if you can, I mean, our job as clinician is to extinguish the fire when there is one, but then it's also to make sure we understand what has led to this fire. And if we can work on the preventive aspect, like correcting the shoeing, the type of exercise the horse is doing, the schedule, the this and that, you will get a much better, like return on injection. Like the injection is going to work longer. So when I do that kind of assessment, I get the impression that, when I speak to people, yeah, the horse is fine now. Can I see it? Oh, no, you don't need to see it because it's all good. It's nothing to compare before I brought it to you. So I think Arthramid is very helpful, of course, but you like any other cases, you have to fix a lot of other things.
And is there any information on the use of the product closer together, if you're giving it multiple times? There's a question from Hadley Sullivan about using
So
it.
you mean like if you repeat the injections or?
Multiple times, yeah, weeks to months apart in the same joint.
I think, I've never done an injection weeks apart, like 1 or 2 weeks apart. I usually give it, so let's say, for instance, I've got a client that is a little bit either skeptical about the product or doesn't want to spend much, and I will use only 1 cc, and I already tell them, like, look, this joint may need probably a 2 cc. And that's also one of the problems that we have with the Arthramid. I would say we don't have a kind of a dose per joint or dose effect curve. But so I usually see them at 4 weeks after, 3 to 4 weeks after. And if the horse is improved and not completely fixed, I may put another injection at this time. So my kind of earliest repeat 4 weeks, otherwise, like anytime after that.
Mm-hmm. And have you any experience with using it in tendon sheath, digital flexor tendon sheath, or the navicular bursa?
No, actually, I don't have a lot of experience with that. I suspect, if the pain originating from the bursa or the tendon sheath is due to some sort of lack of elasticity, as it's been shown in joint, there may be a rationale of using it. But again, from that angle, I have not seen any studies published. So I've used it now once on the navicular bursa, and it's even kind of too early to tell you how the horse is doing because I haven't seen it again. But yeah, I know some people start to use it, and so I wouldn't be the person to talk to you about that because I have very limited experience, limited to none.
And I understand seemed like it was used initially later in disease. So you recommend now to use it earlier in the disease process?
Yeah, definitely. That's the one thing that I've learned with that. You know, when you identify a joint that is painful with little to no changes in the joint, and something that you're not going to be able to solve, let's say a poor conformation or this and that, I even put it very early on in young horses, you know, like 6 to 8 months. We see sometimes horses that are presented with bad OA of the hocks, Arabians, very early on. So probably there was some, as Penny showed, you know, some problem of ossification, and that's been not noticed really, and then they end up having issues. You know, I don't hesitate because I know it's going to be a problem for the long term. So yeah, no, really, I've switched from keeping it, but that's been a long time ago, switched to using it only for like desperate cases to early cases now.
Oh, terrific. Thank you so much. Well, I think it might be time to wind up because we're a bit over time. Thank you so much. That was a really very interesting talk. And thanks, of course, to Arthramid and to all the speakers, and also, of course, to the EVA. And we need to thank also the AVI for helping host the session.